Hello, everyone. I am Cheng-Yu from National Cheng-Kung University Hospital. Today, my topic is a safe and precise tongue-based surgery for adult OSA. For the OSA treatment, as we know, for the patient with CPAP failure, upper airway surgery is a salvaged option. And since 1980, when people received the surgery, the most popular treatment method is the uveolo-palato-pharyngeal we call it the UP3. But for the long-term follow-up the study, we found this kind of patient have some residual obstruction, especially focused on the tongue base. So when the patient received the surgery, the anatomy-based assessment is important because we have to check the nose, the oropharynx, and the tongue base. Some previous literature tell us multiple collapse is common. So nowadays, the tongue-based surgery for OSA, the method can divide it into 4 parts, include tongue-based reduction, suspension, hypoglossal nerve stimulation, and bone surgery. Today, our issue is focused on the tongue-based reduction. When we see the history of the tongue-based reduction, since 1991, Professor Fujita proposed the midline grossectomy. And we can see that the Professor Vicini in 2010, he proposed the TORS. And in 2016, Professor Lee proposed the SAIL. In our hospital, since the 2018, we proposed the intraoperative, the Ultrasound-Assisted TORS. Tongue-based reduction, it is a challenging procedure because the poor access, intraoperative, the hemostasis, and the airway edema, pain management. There are several traditional transoral techniques, but for the patient with the severe lingual tonsil hypertrophy, this method becomes inadequate because sometimes we cannot obtain adequate exposure and suboptimal reduction of the obstruction tissue. So transoral robotic surgery, we call it TORS. It begins since the 2004 and from the University of the Pennsylvania. Since the 2009, FDA permits these 4 diseases can receive the TORS surgery. Nowadays, the main area of TORS in ENT field we can see that include 5 major diseases. Include oropharyngeal cancer, hyperpharyngeal cancer, laryngeal cancer, thyroid cancer, and the tongue-based surgery for OSA. The robotic instruments in NCKU hospital can separate several parts. First is the robotic arms. For example, endoscope camera arm, only 8 millimeters, and spatula tipped cautery and membrane dissector. Also, we use the intraoperative ultrasound. The system is Aroca Alpha 7, and the mini probe, the diameter is only 10 millimeter. And another key instrument is the Davis-Meyer mouse gauge. This is our surgical field set up. We can see that the patient have to hyperextension and to pull out the tongue, and the mouse gauge have to hanging on the Meyer stand to let the oral cavity become the bigger. So how we do it? We use the TORS. We use the transoral robotic surgery system to do the 2 surgery. one is the UP3 and another is the tongue-based reduction. And we have to mention that there are two landmarks have to attention, have to keep in mind. First is the lingual artery, another is the hypoglossal nerve. Hemorrhagic complication is a hot topic for the sleep surgeon. A previous study showed that for the patient received postoperative hemostasis, the prevalence is 4.1%, and then the major complication is the lingual artery injury. So in 2016, Professor Lee proposed that we have to keep 10 millimeter lateral to the midline. So how to establish a safety excision region is very important. Some studies proposed maybe we can do the preoperative CT angiography to identify the lingual artery. So this paper tells us the safe region is the 15 millimeters between the artery and the midline. But we have to know that with the use of the oral retractor and the tongue braid, actually the anatomy, the position of the lingual artery might change. So in our hospital, we try to use the real-time ultrasound to identify the lingual artery. The parameters include the distance to midline, dips, the diameters. We try to create a safety zone. Also, we use the type-pro imaging of the Da Vinci system to help us to improve the safety and the efficacy. So if the audience are interested with our surgical technique, you can scan the QR code. Also in our slide, we also show our the 4 pictures. The figure A shows that we use the mini probe to identify the lingual artery. And when the ultrasound, the screen shows the pulsation signal, we will use our bipolar probe to identify the location, the lingual artery location. Then finally, we use the ruler to measure the distance between the lingual artery and the midline. This slide tried to show example. The patient before the surgery, the patient his HI is 43.5, but after received the TORS surgery, the HI improved and down to 4.8. In the past 3 years, we recruit 93 patients to join the study, and we separate the 2 groups. One is the patient with the IOU positive, another is without the IOU. We can see that the patient who received the surgery with the IOU, they have the shorter operation time, less blood loss, and greater tongue-based tissue volume decrease. For measurements of the surgical landmark over lingual artery, we can see the distance to midline is around 16 millimeter, and the depth of artery is about 5 millimeter. This finding is similar to our we can see the previous studies. We also do a multivariate linear regression analysis, and we can see these 3 variables are associated with the depth of the lingual artery. Discussion. Previous study already showed that obesity increased the tongue fat volume and OSA severity, and BMI was correlated with the tongue weight and the fat percentage. Actually, our study further speculate that obesity led to tongue-based volume expansion and increased the lingual artery distance to the midline. It is well known that the genial glossus muscle is a dilator muscle in the upper airway field. During REM sleep, the GG muscle will decrease its tonicity, so increase the risk of the tongue-based collapse. Also, another study showed that GG muscle, its thickness was correlated with the AHI, and the location of the GG muscle was above the lingual artery. So our study further revealed a positive relationship between AHI REM and the dips from lingual artery to tongue-based surface. In our study, for the patient with the intraoperative ultrasound, it shows that no intraoperative tongue-based hemorrhage and less the breathing complication and the shorter operation time, lower blood loss, and higher excision volume. So for the sleep surgeon, IOU system was useful because precisely identified the vascular structure and confidently performed the tongue-based reduction. For some hospital without the TORS used as a routine surgery, we think the IOU system may still be useful. Conclusions. As we know, this is the first study to examine IOU-assisted TORS for adult OSA. And this surgical technique can locate lingual artery in real time. And for when tongue retraction was performed using a braid, we have to keep in mind that the distance to midline and the lingual artery dips was changed. Yeah. Okay, but with the IOU assisted, sleep surgeon could identify the lingual artery position during the tongue-based reduction. This is the end. Okay, thank you.